Dr. Elilarasi, Director of ICH and Institute, Chennai, is well known and needs no introduction. And without wasting time, please.
Good afternoon, one and all of you. I thank Puduvai Pedicon for giving me this. Okay. Okay. For this wonderful opportunity. I will just talk for 20 minutes about structural management of chronic cough. So what is cough? Cough is an important defensive or protective reflex. It enhances clearance of secretions and particulates from the airways or your tracheobronchial tree and keeps it clean. 40% of our regular consultation comes from cough. Where are all the cough receptors and what is the density? And the cough receptor starts from the oropharynx and it is maximum in larynx, trachea and bronchus. When the pathology is in these areas, you get severe cough. And when it comes to terminal bronchioles, the cough receptors decrease. That is why in the early stages of bronchiolitis and pneumonia, we do not get more of cough, but breathlessness. Then comes your pharynx and sinuses, then the pleura, pericardium and diaphragm. And that is why in pleurisy and pleural effusion and pericardial effusion, we get cough. Last but not the least, we have receptors in esophagus and ear canal. So when you have a foreign body in the ear or you have a gastroesophageal reflex, the presentation may be a cough. Okay, so what is chronic cough? So the definition in American College of Chest Physicians and the Thoracic Society of Australia and New Zealand is more than 4 weeks, and we follow the same. And for BTA says it's more than 8 weeks, but that we generally reserve it for the adults. And though it may look like a trivial symptom for a physician, it is very distressing. Okay, so it is very distressing for the parents and patients, and of course sometimes for the physician as well. So how an analysis of cough can be made and approach be made? Just obviously anything less than 4 weeks, take it as acute. Anything more than 4 weeks, take it as chronic. Ask for history of onset of cough. Look for any clues that is available. Look whether it is dry or wet, and when the timings and triggers, what precipitates a cough or when does a cough occur, whether it's morning, night, etc. So when you take a history, take a thorough history of the age of onset of cough. Any early infancy, we know it is maybe due to a congenital cause. The nature of onset, whether it was acute onset and progressing to lower, or it is a slowly progressive increasing, because both point to a different etiology. When you have an acute, which slowly comes down, usually in a chronic foreign body, because initial cough will disappear because the cough receptors become insensitive to the foreign body, which is lodged and not mobile. The granulation tissue will be formed and the cough will become less, and the foreign body diagnosis may not be thought of. Then whether it's dry or wet cough, whether there are upper airway symptoms, whether there's cough at night or during sleep, or cough with feeds. Then look for failure to thrive. These are the important findings that when you have a chronic cough, you have to look for: clubbing, enlargement of tonsils, adenoids, pharynx and ear. Look for allergic shyness. Look for stridor or hear for stridor, and look for wheeze, whether it's monophonic or a polyphonic or a localized. So this is a case of a dry cough. I think the video is not playing. So what are all the causes of dry cough? Hypersensitivity cough receptors, habit cough, pertussis, tobacco exposure, AC inhibitors, which are taken for cardiac illness, and autogenic cough. So when you take a history, what is the common cause presenting at infants? Airway malicias and vascular malformations always have an onset at early infancy. Then tracheoesophageal fistula, palatopharyngeal incoordination, especially children with central nervous disease like your cerebral palsy. And chlamydia, RSV and pertussis, they can present with severe cough. A word of caution, in very young infants, it can present only with an apnea. In preschool, the common cause one has to, because the children start moving around and they have a mouthing stage and they like to put everything in the mouth, always think of foreign body. Viral infections, which will start as acute and slowly come down and may stop only after 3 to 4 weeks. Asthma, which can occur in any age, has an incidence in preschool and school age more. And passive smoke, either parental smoking at home or in a working conditions or living near a factory, which can give a passive. In school age, the commonest cause being asthma, followed by upper airway cough syndromes like a pharyngitis, sinusitis, and irritants, and habit cough, and TB. Though I put this TB as the last in school age, the tuberculosis should be thought of any cough at any stage in any age group, even in infancy. So some case scenarios of dry and wet cough. Okay, you see a child who's happy, who has a cough of more than 1 month, dry, and I think the volume is not playing. Okay, it's a dry and honking cough. Increases when somebody looks at it. The parents are worried. They have thick files of visiting many doctors, but the child is very comfortable and indifferent, called as labile indifference. So this is a case of habit cough. And this cough totally disappears in the night. If you have a child who has a paroxysmal cough with redness of fever, tears from the eyes, followed by vomiting, and if a bigger child with a whoop, think always of pertussis. But as I said, younger infant may have apnea. And if you have a cough with each breath, that every breath has one cough, it is called a staccato cough. And we know the causes being the atypical infection, especially chlamydia. If you have a cough, a child experiences with exercise, emotion, any environmental factor precipitating, seasonal variation, food-induced, nocturnal cough between midnight to 5 a.m., always think of asthma, the commonest cause. And if you have a barking cough, which is also a dry cough, think of laryngeal pathology, usually croup and laryngitis. So if you have a wet cough, what are all the etiology? If you have a child who has a wet cough and growth is normal, you look for upper airway symptoms. And if the child has a URI, if there is a nasal discharge or cough of less than 2 weeks, it is an acute viral coryza. If it is 2 to 4 weeks, think of sinusitis, allergic rhinitis, and adenoiditis. If there is no URI, but continue to have a 4 weeks, think of protracted bacterial bronchitis. This is purely a clinical diagnosis. In the last 3 to 4 years, we are seeing a lot of cases or possibly diagnosing more of case, which has an excellent prognosis. When you have wet cough with compromised cough, these are the red flags. On those conditions, always think of cystic fibrosis, primary ciliary dyskinesia, immunodeficiencies, necrotizing pneumonias, and neglected foreign body, which when it stays for a long time, leads to a lot of sputum production, loss of protein, and even compromise the growth. And middle lobe syndromes. So this is just nothing but a protracted bacterial bronchitis when the cough is more than 4 weeks, chest is clear, auscultation is normal, X-ray chest is normal, give amoxiclav for more than 2 weeks. Clinical diagnosis alone is sufficient, and usually it is not recurrent. So when there's a recurrence, this diagnosis is not acceptable. So how do you approach cough with the timings? If you have a sudden onset, think of foreign body. If it is immediately after lying down, think of GERD. If it is cough sometime after lying down, we know it is sinusitis with a postnasal dripping. And if it is nocturnal and early morning, it is usually asthma. And if it is early morning after waking up, purulent, we know it is bronchitis. So when you approach cough, you look whether it is a chronic cough, whether it is persistent or it is recurrent. So when it's persistent, always rule out tuberculosis, pertussis, and foreign body. If it is recurrent, whether it is associated with fever or no fever. If it is no fever, we don't worry much. Think of atopy and preterm, sometimes aspiration. If it is with fever, whether it is bacterial or viral. If it is viral, you reassure, wait for 4 weeks. But if it is bacterial and mainly upper airway problems, you think of sinusitis and adenoiditis. But if it is LRTI, we know we are dealing with something more complicated and severe. Evaluate for cystic fibrosis, PCD and PID. So I think, Okay, I think if the chronic cough is associated with breathlessness, yes or no. If it is breathlessness is not present, think of upper airway up to from URI to tonsillitis. If the breathlessness is present, then if it is a noisy breathing, if it is a noisy breathing is yes. If it is stridor or wheeze, stridor, we know we are dealing with airway malicias. If it is a wheeze, think of asthma. If there is no breathlessness, take an X-ray. X-ray is normal. You think of bronchitis and follow up. If X-ray is chest, we know these are the serious conditions. So go for evaluation. These are the only conditions where we think of X-ray, CT chest. But understand, when the child has cough and breathlessness, we should not miss out a congenital heart disease too. So when you have cough more than 4 weeks and red flags, and if there is a red flag signs and X-ray test, it is nothing but a catch-up of workup. If the X-ray test is abnormal to all your CF and PCD and immunodeficiency and retained foreign body, if it is normal, then you consider these diagnoses of URI and sinusitis, post-viral, pertussis, mycoplasma, chlamydia, allergic rhinitis, PPB, asthma, drug-induced, when enalapril, which is given for heart disease, and also propranolol, which is given for children with hemangiomas, and foreign body in the ear because it produces Arnold reflux and cough, and environmental irritants. And if the cough is totally absent in the night, think of habit cough. What are the clues we can get from investigations? When you do a CBC, and if it is abnormally low HB, think of hemosiderosis. If it is low HB with an abnormally high MCHC, think of mycoplasma. If there is a eosinophilia, think of asthma. If it has absolute lymphocytosis, think of pertussis. And from the sputum color, if it is clear and mucoid, think of asthma. If it is cloudy, think of infections. If it is purulent and foul smelling, think of bronchiectasis. Purulent and non-foul smelling, think of cystic fibrosis. And if it is red, it's always alarming. Think of hemosiderosis, necrotizing pneumonia like Klebsiella, and airway bleeds. And we'll see some X-rays with cough. If a child comes to you with 4 weeks of cough, X-ray is like this. We know, looking at it, it's a perfectly a normal X-ray. So our diagnosis usually is acute viral, habit cough, non-specific cough, but we should always know 30 to 40% of the significant illness may have a normal X-ray. So we need to follow up. So if this is everybody's guess, when you have a unilateral hyperinflation, think of foreign body. If you have a right middle lobe infiltrates, think of asthma. If you have findings like your small ring shadows or signet signs, you have a tram track signs, you have consolidations, think of bronchiectasis. If you have bilateral hyperinflation, the commonest cause is asthma, but always think of central foreign body too. If you have cough since birth and you do a barium swallow and you see the trickling of barium into the airway, your diagnosis is tracheoesophageal fistula. And if you have a child who has frequent vomiting since birth, and you can think of, when you have an barium swallow like this, it is achalasia cardia. If you have a child who has cough onset only after weaning, then think of esophageal stenosis. If you have a situs inversus, we know we have to think of PCD. And if you have a cough with stridor and a mediastinal adenitis, think of tuberculosis, of tumor, whether it's a mediastinal teratoma in a younger child or lymphomas and leukemias in a bigger child. So if you have an X-ray like this, what is missing in the second X-ray is the left aortic arch. When the left aortic arch is absent, it means obviously the arch is on the right. When these children present with persistent cough, always have in mind the vascular ring obstructions. So a few case scenarios. A 4-month-old with a consanguineous marriage coming with a persistent cough and weight loss, the previous sibling death, already amoxicillin and azithromycin given, and contact with TB none, and you have a dirty lung looking picture. And some clues may be derived from an ABG. You look at this, the child has alkalosis, the child has hyponatremia, hypokalemia, hypochloremic with metabolic acidosis. And we know it is a pseudo-Bartus presentation of CF and common in the month from March to August. So in these children, a screening test of aquagenic wrinkling, where you dip one palm of the hand in water and keep the other palm as a control, and the maximum of wrinkling, if it occurs within 3 minutes, it gives you a clue that the child will have a cystic fibrosis. If you have a consolidation with a low HB and a high MCHC, then you think of mycoplasma, and you can always confirm it with your blood examination. So what are all the conditions in which we do a bronchoscopy? When you have thinking of airway malacia and the child has repeated aspiration and admission, we have to rule out by doing a, or rather confirm by doing a bronchoscopy. Vascular and external compression definitely requires a bronchoscopy. Foreign body, I'm sorry, the S is missing. Foreign bodies, yes, definitely there's an indication for FOB. Persistent lung inflates also, we have to do a bronchoscopy. So one word about foreign body is that we see so many foreign bodies, especially in this COVID, where everybody was at home. We had classic presentation like sudden onset, choking spells, differential air entry, monophonic wheeze, where it was straightforward diagnosis with obstructive emphysema. But then we had children who did not have a clear history. Either it was forgotten or not noticed. Air entry was normal. It was central foreign bodies. Cough gradually weakens. At the cough receptor become insensitive for the foreign body. Chest clear. So please always have in mind this foreign bodies which don't have a classical presentation. Just quickly, 2 or more case scenarios. You have a 2-year-old child who had fever. No fever, only a persistent wet cough, no weight loss, but there was doubtful loss of appetite. Chest showed minimal crepitation. Child received 2 weeks of amoxiclav, tried azithromycin, but cough persistent. Manto was negative. X-ray chest showed a persistent right middle lobe. CBNAT was negative in the gastric lavage. What next? A child was playful, but obviously the chest infiltrate persisted. So we did a BAL, and then it turned out to be a tuberculosis, which was confirmed, and mycobacteria sensitive to rifamycin. Also, a bronchoscopy will help you in the diagnosis of endobronchial tuberculosis, where when you do a scopy, you see a cheesy material. It is 100% diagnostic of tuberculosis. India is an endemic country for TB in any group, any age group. You have a cough more than 2 weeks with the fever, with or without fever, or there is a weight loss or no weight gain in spite of a good nutritional rehabilitation, always think of TB. If a child who comes with pallor, these are all our own case scenarios, pallor, cough of 4 weeks, tachypnea, pallor was so high that the HB was only around 2.3, PCV was 8.4, and we did a bronchoscopy. It was a blood-stained BAL, and it was diagnosed of pulmonary hemosiderosis. Now coming to treatment of chronic cough. So what are the conditions? This is for the children without any red flag sign. What are all the antibiotics that we have to use? We have so many list of diseases that I've listed out as a cause of chronic, but how many will require antibiotics? Just 3 conditions will require antibiotic, and that only 3 antibiotics. When you have sinusitis and adenoiditis, we use only amoxicillin. And when there is an intensive paroxysmal with post-tussive vomiting, and you have a staccato, which is either pertussis, mycoplasma, or chlamydia, azithromycin. When it's wet cough more than 4 weeks, it is only persistent protracted bacterial bronchitis for amoxiclav. Otherwise, except for red flag, where you need to use more antibiotics, like 3 drugs combination, aminoglycoside, quinolones for CF and all that, only these 3 simple antibiotics are enough to tackle most of the non-red flag conditions. What about the choice of cough syrups? Okay, where and all we have to do for go for empirical therapy. Only there are 2 conditions in which you can give empirical therapy for cough more than, that is when there's a dry cough, you suspect asthma, you can give a trial of inhaled corticosteroids. And if it is a wet cough, trial of amoxiclav. There is no role of trial anti-tuberculous therapy. For antitussives, better avoid antitussives. You give only for children in the post-surgical phase where there's a hernia raphe done, child is coughing, and dextromethorphan is the only accepted antitussive. Never give a combination of antitussive with an expectorant. Second generation antihistamine is only for allergic rhinitis. For a CF, you can give expectorants, but Hypertonic saline is better. And more than 2 years, honey is accepted as it coats the airway. It will suppress the cough receptors. Most of other mixtures and combinations that we have, either they are unethical or we really do not know much about it and we lack evidence. So you better, let's not use it. So say no to empirical ATT in chronic cough, no empirical anti-GERD, no empirical bronchodilators. The carry home is acute viral cough is the most common cause. Avoid medication without diagnosis. Identify pointers on all cases of cough. Always consider foreign body asthma, wet cough evaluation. So thank you for your patient listening.
Thank you, madam, for the scientific dissection of the cough. And finishing in time also, thank you very much. Now the topic is open for discussion.
Thank you, Dr. Ajit, for chairing the session, and thanks to Dr. Bakul Jain Parekh and Dr. Elilarasi for the wonderful talk on atopic dermatitis and cough. I request the chairperson mentors to the speakers, Dr. Bakul Jain and Dr. Elilarasi.